Hello, I'm Dr. Phil Pickett, Professor of Veterinary Ophthalmology at the Virginia, Maryland College of Veterinary Medicine at the Virginia Tech campus in Blacksburg, Virginia. Today we're going to be at the Advantage Ranch in Blacksburg, Virginia, and we're going to be doing a videotape on how to do a detailed ophthalmic examination in an equine patient. Today we're going to show the techniques involved using state-of-the-art instrumentation, but we're also going to emphasize how that you as a veterinary practitioner can do these techniques using what is available to you in the field. We'd like to thank the sponsors of this videotape, Icare Finland, makers of the TONOVET Plus rebound tonometer. Also like to thank Jorvet, the distributor of the Icare TONOVET Plus here in the United States, as well as we'd like to thank the people of Advantage Ranch here in Blacksburg, Virginia, for allowing us to use their facility here in beautiful Blacksburg. There are special considerations for examining a horse compared to examining a small animal patient inside a clinic. Obviously, many times we're going to be out in the field as we are today, and so there are some things that you need to take into consideration. In addition, horses are big, powerful animals, and if they have a painful eye, safety to the handler and safety to the examiner is all important. So the first thing is, if we're going to be examining the internal structures of the eye, or even looking at the cornea, we need to have a minimum of external light. Now, in this video, we will have many staged procedures here where we do have lights on that normally we would have the lights off, so that the person watching this video can understand what we're actually doing. But in the field, having the patient in a darkened stall is optimal. Some people will improvise if they are literally out in a field and use a cape that would be draped over the patient and over the examiner at the same time. This is a little less than optimal, but sometimes this is what we have to do. You need to have a nice quiet area. Horses are easily distracted. They're big, powerful animals. If they start weaving their head back and forth, it makes it hard for you to follow the patient and see what you need to see. It's not like in small animals where you can just kind of hold them still. So having a nice quiet area where there's not a lot of other noise, other horses rattling around, buckets rattling, etc., is always an advantage. In addition, having a good handler, someone that knows horses. Morgan is going to be helping us with Ella today to manipulate the head, turn the head side to side, up, down, and just generally keep the horse concentrating on her instead of what I'm trying to do to examine the patient is very, very, very important. Use of twitches, whether it's an ear twitch, a skin twitch, or a nose twitch or something like that, is indicated only if the patient needs it. Many times if the horse is painful, you do have to distract them with a lip twitch or whatever, and once again having a good assistant is all important in being able to do this. Now let's talk a little bit about sedation. Once again, painful-eyed horses are going to be difficult to restrain and difficult to do what you need to do. And so for the safety of the handler, safety of the examiner, and safety of the patient, sometimes we have to resort to chemical restraint. And so the two most commonly used chemical restraints, and the ones that I tend to use, are xylazine and ditomidine. These are both alpha-2 agonists. The dose that I like for xylazine is a 0.5 milligram to 1 milligram per kilogram of body weight. For ditomidine, 0.01 to 0.02 milligrams per kilogram. These are both given intravenously. Xylazine gives you about 20 minutes of a good still head. They give you muscle relaxation as well as analgesia. Both of these drugs do that. Okay, but after about 20 minutes, even though the patient is still somewhat sedate, we get sort of a head bob phenomenon. So if you're actually trying to do a procedure like place a lavage system or something else where you're manipulating and you need a really still head, just take into consideration that you only have about 20 minutes. Now, ditomidine lasts longer. Most of the time I can get a good 40 minutes out of a single intravenous dose of ditomidine at the dosage that I just listed. Some people like to top these off with an opioid, and the most commonly used opioid is butorphanol. Butorphanol at a dose of 0.01 to 0.02 milligrams per kilogram will enhance the alpha-2 agonists. The problem that I don't like with butorphanol is the butorphanol tends to have a lot of head bobbing. So when I'm doing restraint to do some sort of manipulation around the eye, I'm trying to slice a piece of cornea off for a keratectomy specimen or whatever, I really don't want to have that head bobbing, and so I usually do not use butorphanol. A lot of people like acepromazine as a sedative. Acepromazine does nothing to control the head movement. The horse can be totally sedated and they're still weaving their head all around. So for most ophthalmologists, acepromazine is not a really effective drug. And then lastly, a very important thing is to be able to open the eyelids. In a very painful horse, their orbicularis muscles are extremely strong, and you basically cannot overpower them. You will not see what you're going to need to see. So, and then in addition, if you had a fragile eye, say a lacerated eye or an eye with a deep corneal ulcer, the last thing you'd want to be doing is putting a lot of pressure on the globe and potentially causing the globe to rupture. So what we're going to do is we're going to show later here how to do a palpebral nerve block. The palpebral nerve originates at the base of the ear, runs down the zygomatic arch, and then splits and goes to the orbicularis muscles of the upper lid and the lower lid. And this is what allows the horse to squint or blink actively. Once that is in place, the animal can still move their eye, and they can passively raise and lower their upper lid, and they can still pull their eye back in the socket, which causes the third eyelid to go across. But at least you can open the lids so you can do things like tonometry or a better examination without having to worry about the patient constantly squinting or blinking because of they're either painful or they're resistant to the fact that you're shining a bright light into their eyes. So the gross examination is pretty much the first part of the examination, and this can be done in a lighted situation. You can do this out in the parking lot. You can do it out, anywhere where it's light, because we're just going to be looking for gross abnormalities of the head, the surface of the eye, etc. If there's a history of vision impairment, this would be a good time to actually evaluate vision. You can have a patient walk a curb. Sort of a serpentine walking back and forth over a curb to see whether or not the patient stumbles. If there's a history of one eye being problematic and the other eye not, you can actually take gauzes and some elasticon tape and blindfold one eye and then repeat your serpentine walking. This way, if there is an abnormality, when you cover the good eye, the abnormalities are a little bit more emphasized with one eye or the other. So what I'm going to start with here is I'm going to look for facial symmetry, and to do that I'm going to actually look straight on at the patient. And at this point, if we want to look for equality of the pupils, I can stand back and shine the light in and see the reflection from the back of the eye in both eyes at the same time. This is very, very difficult to test for anisocoria or inequality of the pupils if you can't see both eyes at the same time. After I look at the initial symmetry from side to side, I'm basically going to look at each eye individually. We're going to look for any abnormalities of the lid margins, any malposition of the globe. Is the eye deviated either medially, laterally, ventrally, or dorsally? We're going to look at third eyelid protrusion. This is a good point to actually do your palpation of the orbital rim. Basically, you're feeling the bony structures. Is there anything that is painful to the patient? Is there any irregularities, as if there's been a bone fracture, any swelling? If you were looking for a sarcoid, you might see feel a thickening of the lid or a hard thickening or something. So these are the things you're going to do with your gross physical examination. The neuro-ophthalmic examination evaluates basically the cranial nerves that affects the eye and adnexa. There are a number of different tests that we're going to do. The first is called the oculocephalic reflex. And the oculocephalic reflex is basically eye position in relationship to the head. If you tilt the horse head up, they tend to roll the eye down, and so you don't see the ventral portion of the eye. If you want to see the ventral portion of the eye, say you're looking for chorotic precipitates in a uveitis horse, you would tilt the head down, and they tend to roll their eye up and seek the horizontal. Also part of the oculocephalic response is basically the movement of the eyes as you move the head back and forth. There should be a saccade that follows the movement of the head. The menace response is a learned response. It's not a true reflex. And this is what a lot of people do to evaluate whether or not a patient has the ability to see. Realize, of course, that corneal opacities, cataracts, and a number of other things that do not directly involve the nerves can affect the menace response. Also, sedation will affect the menace response. The menace response is a simple test to perform. You perform a menacing gesture to the patient, and they will actually blink in response to what they consider to be something coming at their eye and is going to injure them. Okay, and you can do this obviously on both sides. Another response, actually it's a reflex, is called the palpebral reflex. The palpebral reflex is where we touch the patient and the patient actually blinks associated with tactile sensation. And the medial aspect would be the ophthalmic branch of the fifth cranial nerve, and then the lateral aspect is be the maxillary branch of the fifth cranial nerve. All of these tests need to be performed before you do your palpebral nerve block, because then the patient cannot blink as well, and therefore there's not going to be able to evaluate whether or not they are responding appropriately. A response that, or a reflex, excuse me, that is really important as far as evaluating vision is what we call a dazzle reflex. So the dazzle reflex is a bright light shining directly into the eye, and this elicits a blink, a retraction of the globe, sometimes even a turning of the head. So in a very darkened stall, if you'll take a very bright light and shine it quickly into the eye, the patient will blink, and that's an indication that basically the brain stem, the retina, and everything else is working. This is an important response because the menace response, as I said, could be affected by sedation and other environmental stimuli. If the horse is excited, sometimes the menace response is not as crisp. Lastly, is the pupillary light responses here. If I shine a bright light into a horse's eye, I expect the pupil to constrict. That's a direct pupillary light response. If I have my assistant looking at the other eye, I can expect the pupil in the other eye to also constrict. This is a reflex in the brain stem, and that's called a consensual pupillary light response. So if I shine in this eye, and if Morgan is looking at the other eye, she will see the pupil come down. If you have a deficit, if I shine a light in the eye and the pupil doesn't move at all, it could be because the iris is stuck to the lens, what we call synechia, or it could be that there is no light perception whatsoever. If I shine a light in the right eye, the pupil does not constrict, and the left pupil does not constrict, then that indicates that the right eye has no light perception. A way to check this is to shine the light in the left eye and see the pupil constrict. If the right eye is blind, basically that pupil will constrict, and I swing the light over to the right eye, and the pupil will actually dilate while I'm shining the light in it. This is called a Marcus gun sign, and it indicates that the right eye would have no light perception whatsoever. So following the neuro-ophthalmic examination, and prior to examining the globe itself, this is where you might want to do a palpebral nerve block. Basically, a horse who has a painful eye is going to be able to keep their lid closed over my best attempts to keep the eye open. Okay, and so what we want to do is take away some of that power of the orbicularis oculi muscles to close the lids, and we're going to do this using lidocaine and do a palpebral nerve block. So basically what we're going to do here is block the palpebral nerve as it comes across the zygomatic arch right up here at the very top, or some people like to block this down here at the supraorbital fossa area where they can palpate the nerve rolling underneath. So here I've drawn up 3 milliliters of 1% lidocaine. I like to use a small needle. I like to use a 25 gauge needle. I'm kind of empathetic for my patients. It's a whole lot less painful if you're poking around with a smaller needle than a larger needle. So now we're going to do the palpebral nerve block so that we can hold the lids open without putting excessive pressure on the globe. We'll be able to see the patient's eye better, be able to check pressures, do minor surgical procedures, etc. Some people like to use saline, some people like to use alcohol to wipe over the area that we're going to basically be injecting. You got to be careful with alcohol that you don't get it actually in the eye. I'm going to use saline here. Basically I'm just going to wet my gauze down here real good, and I'm basically going to wipe this down, getting any dirt and debris off. Also mats the hair down a little bit if you've got a horse in the middle of the winter with a big full coat, so you can actually see as well as palpate your landmarks. I'm going to take my lidocaine. I'm going to palpate the nerve here. And I usually pinch directly over and lay the needle sticking. And then I'm going to massage. And the massage will spread the lidocaine over the nerve. And when we have adequate akinesia, the horse will be able to lift their upper lid, because that's a different nerve. That's the third cranial nerve, the oculomotor nerve. But they will not be able to spasm the lid like we were showing before. And so we'll be able to open their lid a whole lot better. So now that we have done our palpebral nerve block and we can easily see the whole eye, this is where we do our detailed external and surface ocular examination, which is very important in the horse. See a lot of surface ocular disease, tumors, foreign bodies, corneal disease. This is a very important aspect of equine ophthalmology. The best instrument to use for the detailed examination would be the slit lamp biomicroscope. This is a portable slit lamp. Some people call it a pediatric slit lamp because it is used in little children. And it can also be used in nursing homes and everything. And some people even call it veterinary slit lamp because we have to use it on our veterinary patients. So the principle behind the slit lamp is that you have a microscope for magnification, and then you have an adjustable light source. All right, and so what I'm going to do here is I'm going to basically make the light source a bright, wide light, and this will allow me to just generally look at the surface of the eye. And so this is what I'm going to be doing right here, is I'm going to gently pry her lids open, Ella's being a good girl, and I'm just going to scan across. I'm going to look at the lids. I'm going to look at the third eyelid, going to get the third eyelid to come up. I'm depressing the globe. I can look at the surface of the cornea and look at the anterior chamber. Okay. And for looking at depth perception and to see things like aqueous flare, murkiness of the aqueous humor, I can make a small beam of light. And when I shine that into the eye, it's almost like I have a physiologic slice of the eyeball that I'm looking at. It's almost like taking the eye in the head and putting it under a microscope and looking at the section just like a pathologist would do. This is all well and good if you have a $5,000 slit lamp. What I'm going to basically do now is show you how to utilize the equipment that the average practitioner would have at their practice or on their truck to do the same examination of the external eye and the cornea. So first, for magnification, everyone is familiar with reader glasses. This 3 diopter lens will allow you to get 1/3 of a meter from the surface of the animal, so that's about 13 inches. Likewise, some people use these optivisors. And basically this is a 5 diopter optivisor here, which allows me to focus at an eighth of a meter, or excuse me, a fifth of a meter, which is 8 inches. So when I put this on, I can get even closer still and be able to see things in focus, and the close proximity allows me to have bigger magnification. So the next thing we're going to need is a light source. And you can use your direct ophthalmoscope and just basically use the large spot of light. And what we do is we're going to basically use this as our light source, and we're going to shine the light at different angles to what I'm looking at, just like we were using the slit lamp. So any light source would work for you with that very simple technique. You could use the Finoff transilluminator, would do the same thing. Okay, so now let's learn how to utilize our direct ophthalmoscope a little bit more for the even closer magnification and closer looking, utilizing what we call retroillumination. The diopter wheel allows you to adjust the different diopters, which allows you to get closer and closer to the patient. A 10 diopter lens will allow a person to focus at 1/10 of a meter, which is about 4 inches, which is double the magnification I got using the optivisor loop on my head. So if I wanted to look at the surface of the eye from 4 inches away, basically I put my hand on the halter, gently raise the lids and look through, and I can focus. Have a little dust in the tear film here, but I can focus from 4 inches looking at the surface of the eye. If I want to look at structures deeper into the eye, like the iris, I simply move forward. And now the iris will be in focus because it's a little bit further away from me. If I wanted to look with even more magnification, I could even turn this up to 20 diopter. Now 20 diopter is going to focus at 1/20th of a meter, or 2 inches. So if you were looking for little tiny fine chorotic precipitates from a horse that has uveitis, and you want to look at the bottom of the eye and see those little bitty tiny dots that are so important diagnostically, this is how you would do it. You can see that I'm really, really close to the eye and things are really, really magnified. Okay, so that's how you would use your direct ophthalmoscope to evaluate things. Another piece of equipment that many people have available, that a lot of people like to use, especially large animal practitioners, is actually the otoscope. Now the otoscope, a veterinary otoscope, has a 10 diopter lens, and it's going to focus at 4 inches. That's the length of the otoscope cones. And so with the otoscope, I can put this on, and looking through the lens, I'm going to be able to focus at things at 4 inches, just like I did with the direct ophthalmoscope. But I'm going to have a lot larger lens to look through. And so I can look at the surface of the eye from 4 inches away, or I can move in and see the iris in focus at about 2 inches away. And I have a nice big large lens to look through. So many people like to use the otoscope. Okay, so this is both of these direct ophthalmoscope and the otoscope have what we call coaxial illumination. The light is coming through the aperture that you are actually looking at. And so this allows you to also develop a concept called retroillumination. If I shine light into a patient's eye, a veterinary patient, dog, cat, horse, cow, you're going to see the bright reflection through their pupil of the tapetum. And anything that is between you and the back of the eye is going to be backlit by the light reflecting from the tapetum. So this is a very good way of picking up little small opacities in the cornea, the lens, the vitreous, or any other portion of the eye that is between you and the back of the eye. So what I would do here is I could turn the ophthalmos or the otoscope on and flip the lens out of the way, and I could stand back, you know, a number of feet, a couple of feet, and get the reflection. Or I could flip the lens in and I could look a little closer, and by moving around I could see if there was any opacity in the lens against that backlighting, or if there was any debris floating around in the vitreous, what we call floaters. And so this is how you would use the process of retroillumination to see things in the front of the eye by them being backlit. Now that we have completed the detailed extraocular examination, this would be a good time to check intraocular pressure. Intraocular pressure is pretty important in the horse to diagnose low intraocular pressure, which would be seen secondary to uveitis, which is a common disorder in horses. We do see glaucoma in the horse, but not with the frequency that we do in our small animal patients. Glaucoma in the horse is very rarely a primary disorder like it is in the dog and in the human being. Rather, glaucoma, elevated pressure in the eye, is usually due to chronic changes in the eye associated with uveitis or moon blindness, equine recurrent uveitis. So the way that you're going to measure an intraocular pressure is with an automated instrument. So here we have the TONOVET Plus, made by Icare in Finland, distributed in the United States by Jorvet. This instrument works on the principle of a magnetized pen with a plastic tip that is actually shot from the instrument and touches the eye and then rebounds back into the instrument. If you think of the principle of dropping a golf ball on concrete, the golf ball will decelerate when it hits the hard surface and then it will bounce. If you did the same golf ball drop on a pillow, it would decelerate much slower and it would not bounce. And so this is the technology basically of a rebound tonometer, which is the Icare instrument. So basically, turn the instrument on. You take off the little protective cover here. We need to make sure that this is set up for the horse, which we have it set up for the equine. This particular instrument is calibrated for 4 species: the horse, the dog, the cat, and rabbits. So here we've got the horse setting. When we activate this, it will tell us that you need to load the instrument. And so this is where we're going to load these little pins that come in separately wrapped sterile containers. So here we have the little container here. I'm going to take the top off. I'm basically just going to drop this in, and you can probably just barely see the little tip here. So now that we have loaded the pin into the instrument, notice the light on the tip. The green light indicates that the pin is parallel to the ground. Since this is a principle of deceleration and rebounding back into the instrument, if the instrument is tilted up, you can see that the red light comes on telling you that you're not in the right position, in the right plane. Or if it is tilted down, you're either working with or against gravity, which actually alters your readings and makes your readings inaccurate. So when the pin is parallel to the ground, the tip will tell you that you are in the right position and you have a green position. I'm now going to take the pressure in the eye. We have a blocked lid, so we're not going to be putting any excessive pressure on the globe. If you had a patient that you did not have a blocked lid and they were very blepharospastic or squinty-eyed, you might have to block the lid so that you wouldn't put excessive pressure on the globe. So there's a little button on the back here. This is the activator button that you push, and this will, every time I push the button, it will shoot the pin and it will touch the cornea and it will bounce back. Because this is so small and so light, we do not have to use topical anesthetic. Most patients do not feel this and are very unresponsive to this. So I get my light to where it's green. So basically the instrument has taken each reading. Every time it got a reading, there was a beep signifying that indeed it had taken a measurement. Usually it takes 6 readings and it averages them. It throws out the high reading, the low reading, and then it averages the rest of the readings. And you can see that we have a pressure of 19 millimeters of mercury. In addition to being able to take individual readings every time I push the button, the activation button, the Icare TONOVET Plus instrument has an additional mode where you can push the button, hold it down, and it will automatically shoot the pen out 6 times and take readings. So basically we're going to do the same thing. I'm going to gently raise her lid. I'm going to get in position here. And so basically what we've done there, instead of individually pushing the button, the instrument did this for me, which allowed me to hold my hand steady and concentrate on being steady. We see that we've got the same pressure, 19 millimeters mercury, that we had when we did it individually. There are a number of things that can alter intraocular pressure in the horse. Decreased intraocular pressure is usually secondary to inflammation in the eye. So horses that have equine recurrent uveitis or have uveitis associated with some sort of surface ocular irritation, a corneal ulcer, a corneal foreign body, stromal abscess, whatever, these horses, their intraocular pressures sometimes can be less than 10. And so this is one of the things, now that we have the capability of surgically and medically treating equine recurrent uveitis that we haven't had in the past. Early diagnosis with tonometry and intraocular pressure support of a diagnosis is very, very important. Position of the head. A patient that has their head down will basically have an elevated intraocular pressure, just like your intraocular pressure would be elevated if you stood on your head. An additional abnormality that could cause decreased intraocular pressure would be sedation. Any drug that lowers the blood pressure, whether it's an alpha-2 agonist, acepromazine, any of those drugs, bitorphenol, all the drugs we talked about before, can erroneously cause a lower intraocular pressure than what might be the case. In the horse, glaucoma, as we said before, is very uncommon. The horse does not experience primary glaucoma, as is commonly seen in dogs and in human beings. Intraocular pressure in the horse is fairly volatile. If you excite a horse, if I jerked Ella around here and got her really good and excited, I could elevate her intraocular pressure anywhere from 5 to maybe as much as 10 millimeters mercury just with that excitement. Glaucoma in the horse is usually secondary to equine recurrent uveitis and scarring of the filtration angle, and the pressures sometimes can be in the 30s, 40s, even 50 millimeters of mercury or above. And the problem with equine glaucoma is that the pressure doesn't always go up and stay up. If you've checked their pressures 5 times during the course of the day, they may be normal twice during that time, and the other 3 readings could be 50, and that's just the nature of the beast in horses. The other way to measure intraocular pressure in the horse is the use of applanation tonometry using an instrument like the TonoPen applanation tonometer. This instrument requires topical anesthetic. So basically we're going to use 1% proparacaine, and to keep from contaminating the bottle, we're going to place it in a tuberculin syringe so that there's no potential of contaminating the bottle with tear secretions. I'm going to take the plunger out. And just going to drop some drops in there. Use about 3 or 4/10 of a mil will be adequate. Proparacaine takes approximately 30 seconds to numb the surface of the eye, and the effect lasts for maybe 10 minutes. There's another drug that we will sometimes use for more diagnostic or surgical manipulations of the cornea. It's called tetracaine. And tetracaine is in a gel, which you wouldn't want to use with tonometry because it actually affect your readings. But if you were doing something a little more invasive like scraping the cornea or something, the tetracaine may numb the surface a little bit better. So basically what I'm going to do here is I'm going to take my syringe and just let this dribble over the surface of the eye. and numb the surface of the eye. Now, some people will actually squirt the horse in the eye, like that. After about the second time, most horses are going to realize what you're going to do, and it's going to be a lot harder than that to do. Of course, we've also blocked the lid so that she cannot blink as well as she could otherwise. You can see it's starting to wear off a little bit, our lid block. So now to prepare the tono pen, this is an applanation tonometer, and it has a tip that has a transducer within. We're going to have to cover that with a little protective cover made out of latex. You want to put the little tip over there so it's not too tight or too floppy and loose. Basically going to activate the unit by pushing the button, and you get two lines. The tono pen requires that you develop the technique of actually touching the eye to get a good reading. But when you get when you take the reading, it has a number of clicks instead of beeps like the TONOVET, the Icare instrument. It averages the numbers, and then it gives you a reading of intraocular pressure. Now that we have checked our intraocular pressures, we have dilated the pupils so we can see the deeper structures within the eye. We can see the lens, we can see the vitreous, we can see the posterior segment. At this point, one can use the slit lamp biomicroscope to evaluate the clarity of the lens and to see if there's any debris behind the lens in the anterior vitreous. This would be a very common abnormality seen in a horse that has uveitis or inflammation within the eye. So we've already shown how to use the slit lamp biomicroscope, but what I'm going to use here is the direct ophthalmoscope with the slit beam as my light source. I'm going to use my optivisor loop here to use for my magnification. I'm going to show the technique of looking at the lens and at other structures using the slit beam. And so the idea is you're going to shine the light oblique to the angle that you're looking at, and this gives you the 3D depth. And then I can change this. I can come from this side and I can look from the other side. And so we can see the three images, the one on the cornea, on the lens, passing through the lens, and in the lens. Being able to see if the beam is non-existent between the cornea and the lens is going to tell us if the anterior chamber, the aqueous humor fluid, is clear. Animals that have uveitis will have murky anterior chamber fluid or aqueous humor, sort of like your headlights shining in the fog. This is called the Tyndall effect. Another method of looking at the deeper structures in the eye without a magnifying loupe is to actually use the diopter wheel of the ophthalmoscope. Earlier we talked about using the 10 diopter lens and weaving and bobbing and seeing the surface of the eye, the iris, and now that the pupil is dilated we can actually see the lens itself. Likewise, we can also use the otoscope head, and by weaving and bobbing in and out we can see the lens in focus just by moving in towards the eye, similar to what we would use for the direct ophthalmoscope. So what we're going to first do here is use the direct ophthalmoscope. I'm going to place my hands pretty close. This is going to be done at about 2 inches. We're going to use this technique to evaluate the surface of the lens. And the anterior vitreous. We can take this off. Can put the otoscope on with its lens in place. When we do this, at 4 inches the surface of the eye is in focus, and when we move in the lens will be in focus because it's farther away from you and I've moved in. And so this is how you can use your otoscope not only to look at the surface of the eye, but also some of the internal structures. To look at the ocular fundus, the retina, optic nerve, tapetum, non-tapetum, we can also use the direct ophthalmoscope, and you can also use the otoscope as well. Because the eyeball is a optical system unto itself, light from infinity focuses on the back of the eye. So when we use the ophthalmoscope, we use the 10 diopter lens, which focused at 4 inches, to see the surface of the eye at 4 inches. We use the 10 lens to look at the lens of the eye by moving inward. The back of the eye will be in focus for the average human being if the horse is not nearsighted and if you're not nearsighted at a 0 diopter setting, which is what I've put it on here. So to look in the back of the eye, basically I'm going to get about 2 inches away from the surface of the eye, and I'm going to move around to see different structures in the back of the eye: the optic nerve, the non-pigmented shiny tapetum lucidum, and ventrally the dark pigmented tapetum nigrum. Now if you were doing this with an otoscope, we already said that the otoscope has a 10 diopter lens. When we flip the lens out of the way, though, there is no lens. It's like a 0 diopter lens. So many equine veterinarians like to use their otoscope not only to examine the front of the eye with the lens down, but they flip the lens up and they can see the exact same thing as the 0 diopter on the direct ophthalmoscope, except actually you're looking through not quite so small of a hole. So many people prefer this over using a direct ophthalmoscope. So this is doing direct ophthalmoscopy using an otoscope or using the direct ophthalmoscope itself. Indirect ophthalmoscopy is a diagnostic technique used to look at the back of the eye, the fundus, the retina, optic nerve, tapetum, non-tapetum, using a condensing lens. So what we have here is a 20 diopter condensing lens that we're going to use a light source and a special instrument called an indirect ophthalmoscope that I'm going to put on my head. And this allows me to use the condensing lens to see the back of the eye. The difference between this and direct ophthalmoscopy is, one, this sometimes will allow an examiner to look through more cloudy media. You can have a partial cataract, you can have a cloudy aqueous humor, cloudy cornea, and you might be able to see the back of the eye a little bit better than you can with the direct ophthalmoscope. The other advantage to this is you see a wide panorama. Direct ophthalmoscopy looks at a very small area, about the size of the optic nerve. And to look at the back of the eye, you have to move around and move around and move around. With indirect ophthalmoscopy, you see an area 30 or more times larger than you do with direct ophthalmoscopy in the horse. The disadvantage is that the image that you're seeing in this lens is what is called a virtual image. It is upside down and it is backwards. Left is right, right is left. And so this takes a little bit of getting used to. The other advantage is you are doing this at arm's length, which in the horse is not such a big deal, but if you were dealing with a fractious cat or a dog and your face is right there next to their mouth, this could be a problem. So what I'm going to do here is I'm going to put this scope on, and you can see I'm going to line this up so that the light is shining on the horse's eye, and then I'm going to take my condensing lens, and this is done at arm's length. I'm basically going to look at the back of the eye through the lens. And I'm going to move around to see different structures. If I want to see the top of the eye, I actually get down and look up. It's as if there was a stick going from my eye, my instrument, through the patient's eye, and the pivot point of that stick is the patient's lens. If I want to see medially, I swing out here laterally and look across. If I want to see laterally, I swing out medially and look across. And so this is how you do it with the indirect ophthalmoscope. Next, we're going to show how to do this in the field using what you have available to you. So to improvise using the equipment that you might have available to you in practice, we're going to use a simple headlight. Single light bulb varieties work better than the multi-bulbed LED expensive lights. You can pick these up at any discount store, hardware store, whatever. That's going to be my light source, and I'm going to put it on my head and have it down right by my eyes so that I'm almost looking right down where the light is shining. As my lens, I've got a little 20 diopter lens here. This is a lens that you can buy at the hobby shop for looking at stamps or looking at any other small items. And this is exactly the same diopter as the lens that I was using that cost, hundreds of dollars. Lastly, because I'm presbyopic and I can't see up close anymore, to enhance the image that I see, I'm going to use my little 2 or 3 diopter reader glasses that I got earlier and I was using to look at the external eye, and this is going to allow me to focus on that lens that is only about 20 inches in front of my face. So I'm going to put all this together, and we're going to do the technique of indirect ophthalmoscopy using a headlight and using an inexpensive lens as my condensing lens. I will line things up exactly like I did before. Basically, Ella, I'm going to get her to open her eye here, and I'm going to put my condensing lens up, and I'm going to look at the back of her eye, just like I did with the fancy high-dollar instrument. Okay. So if you don't have a headlight, you can also use some other light source. And many people will use their direct ophthalmoscope. People will use just a flashlight. The idea here is that the illumination has to be coaxial to your line of sight. So this is where the direct ophthalmoscope actually works very well. Because when you're looking through the direct ophthalmoscope, the light is shining exactly where you're looking. So with this technique, I'm holding the instrument with one hand and I'm holding the lens with the other, and I'm not going to be able to hold the lids open. So this is kind of a negative for that. But Morgan is going to help me out here, and she's going to hold Ella's eyelids up. Now, a couple of tricks here, or a couple of pointers. You need to hold the instrument with your non-dominant hand, because the manipulations with the lens are much more important and much finer than is holding the instrument. So a lot of people, they want to hold the instrument with their dominant hand, and then they try to use their non-dominant hand to do the fine tune, and they just don't do as good a job. So what we're going to do here is we're going to get Morgan to swing around here, and she's going to hold it, and I'm going to shine this light on her eye. I'm going to use a 2 diopter just like my other lenses were. I'm going to shine the light in her eye, and I'm going to look. I'm going to see the back of the eye. Move around just like I did before. And so that's how you would do indirect ophthalmoscopy using a handheld light source and an indirect lens or condensing lens. And this happens to be an inexpensive lens. The third eyelid in the horse is a major protective mechanism. When the horse retracts the globe, the third eyelid slides across the eye, distributing the tear film and also protecting the surface of the eye from foreign material. Unfortunately, things can accumulate behind the third eyelid, like foreign pieces of material, seeds, hay, weed particles, etc., and can rub and abrade the surface of the cornea. The third eyelid can also be involved with squamous cell carcinoma or cancer eye. And so being able to evaluate the third eyelid is an important part of an ophthalmic examination. If I retropulse the globe, the third eyelid will come across the eye. And you can see that here as it moves across. After we apply topical anesthetic to the surface of the eye, we can use a forceps to gently retract the third eyelid to look behind the third eyelid, between the third eyelid and the globe itself, once again looking for foreign material, etc. And we can also utilize that to pull the third eyelid up a little bit more so that we can see if there's any tumors, squamous cell carcinoma, on the front surface, or the leading surface, the palpebral surface of the third eyelid. So basically what I'm going to do here is I'm going to retropulse the globe, and then I'm going to reach in with a forceps and grasp. After we have finished with our thorough ophthalmic examination, especially if we've done a lid block and the patient is not able to close their lids as effectively as they might normally be able to do, sometimes the application of a lubricant ointment is indicated to protect the eye while the local block is wearing off. Local blocks can usually last anywhere from 3 to 5 hours, depending on how much lidocaine was injected into the site. So what we're going to do here is we're going to use a tuberculin syringe. The reason I like to use a syringe is it's very rounded and very smooth. Most ointment tubes are fairly smooth, but sometimes they can be a little on the sharp side, and I've actually seen corneal ulcers from owners accidentally scraping the surface of the cornea trying to apply ointment. So similar to what we did when we did the topical anesthetic or any other ophthalmic drop, is we're going to take the plunger out and we're going to put some ointment into the tube. Now if you were treating a horse with some sort of ocular disease, maybe has a corneal ulcer or some other abnormality, where you actually were wanting to treat with more than one drug, you can actually put the first drug in, follow it with the second drug, then put the plunger in and sort of swish these all together and then deposit that, minimizing the numbers of times that you actually have to put something next to the eye and potentially scratch the eye. I found that medially the third eyelid protects the eye, and so what I usually do is I will apply this to the medial aspect of the lid. I use my thumb to depress the plunger and basically just express this into the cul-de-sac. You can see it in the lower lid there, and then I close the lids and let the body heat melt the ointment onto the surface of the eye. So now if you look at this, you see the ointment film is on the surface of the eye. So now that we have completed our video on the ophthalmic examination of the equine patient, we would hope that you could take this information with you in your practice and utilize these techniques to do a more thorough ophthalmic examination on your patients. We would like to thank Icare Finland and their TONOVET Plus rebound tonometer for sponsoring this videotape, along with Jorvet, the distributor here in the United States for the Icare TONOVET Plus. We'd also like to thank Advantage Ranch here in beautiful Blacksburg, Virginia in the southern Appalachian Mountains. I'd like to thank Morgan for her assistance today. And most especially I'd like to thank Ella, who was a real trooper today and was a good girl, so we could do all these wonderful techniques and you could learn all this stuff. Thank you very much.